All right, y'all. Good to see all of your faces. I'm excited to talk to you about this. This background here is the the Coca-Cola vault where their uh their ancient recipe is kept in ridiculous location in case anyone steals it. So that's that weird background. So today I kind of wanted to discuss with y'all nerve block adjuncts. So this is kind of a case that we had where this dude had some posterior rib fractures and he literally bounced back two more times to get two more ESP blocks. So as we kind of do all these blocks and we send a lot of people home trying to figure out, what we can do in terms of a single injection block that will really kind of get someone like the longest duration of anesthesia without causing a ruckus at the same time. So that's what I want to discuss with y'all today. Uh, I was pretty interested in this list here. This is actually my institution's cost list for all the different anesthetics and how much it costs per vial. And you can see, honestly, a lot of it's like pretty darn reasonable until you get to the Exparel, and then it's like literally like 100 times the cost of regular bupivacaine, which is just insane. But there's a lot of different things to think about in terms of, can your department even get the anesthetic and the adjunct, and what's the cost, what's the duration, and what are the side effects? So that's kind of want to review with you and kind of just see what y'all think in terms of what we think is gonna be the next step. And I think a lot of us are probably still using Bupiv and Dex. And kind of one thing I kind of want to push and kind of see what you all think about is whether or not we should actually be switching to using Ropiv with buprenorphine. So, I mean, I think some people are still, I don't know if anyone's using catheters at all. If you are, shout out. But I mean, as far as I'm aware, really no one's really using these, nerve block catheters. You have to go full sterile for it. A lot of them are getting dislodged from what I hear. And a lot of these people are getting sent home too. So the concept of getting pumps and then getting people sent home with pumps sounds kind of ridiculous in the setting of the ED. And then so you have your good old fashioned staple, the Bupiv index. And maybe at the end of this, you guys can say, well, what are we talking about? We should just stick with the Bupiv index. But I kind of want to push envelope and see if we can, there's something better. So there is this Exparel. I had a recent surgeon ask us why we weren't using Exparel. It, you know, for us, it's literally 100 times more relative to using the regular bupivacaine. And a lot of the literature I've read says that it's probably not worth it. I don't know if anyone has experience using that. If you do, please feel free to chime in here too. But this was an RCT using Exparel versus Bupiv index with over 110 patients for shoulder surgery. And kind of all the outcomes that you would care about were all the same. So looking at, opiate consumption, looking at patient satisfaction, and then looking at the analgesia difference, there really wasn't too much different across these different groups. So, it really kind of makes me wonder, even if we would get the Exparel, is that even worth it, especially with how much cost it is? So Lacey said that they were using some catheters, which is pretty cool. So and then kind of I don't know how many of you are using Ropiv versus Bupiv, but it does seem like there's some theoretical benefit in terms of trying to reduce those last cases. So there's some like ancient literature looking at, kind of doing these volunteers and, comparing Bupiv versus Ropiv head to head. There is some increase CNS symptoms with bupivacaine. And then obviously the increasing cardiotoxicity, which is the primary concern why a lot of people, kind of push towards that. And, Scott Weingart in a recent podcast, was complaining, saying, why in the hell is anyone using bupivacaine when we have ropivacaine anymore? And I try to really look at like the difference in terms of duration between these, but all the studies that I said kind of said that they're pretty darn similar. So then if you try to use Ropiv, but then you want to add Dex and the duration, you kind of can't because any higher pH substance with Ropiv is going to just precipitate out and that can have some neurotoxicity and be bad. So you can't really use Ropiv in Dex. So, what should you do instead? Has anyone used REC? I know like EVMS in Norfolk's using some REC for some like brachial plexus blocks and stuff like that. But a lot of the FDA approval is all driven by all being intra-articular. But so it's kind of like Ropiv, and it's got this like, pre-constituted solution primarily out of like one pharmacy. It sounds like other pharmacies may be able to constitute it, but it's kind of this like preconceived solution with Ropiv, epiclonine, and ketorolac. And a lot of the primary stuff is all driven out of being, intra-articular for a lot of like, knee replacements and stuff like that. So this was kind of, there was like a couple studies looking at it with like perineural. Um, so, but I think it's at least interesting, and I'm not aware of like any robust evidence in terms of that we should be pushing that. And we'll be talking a little bit more about that clonidine piece. Here's just the Dex background, just kind of saying it's, a lot of studies say it's about like 6 hours, by far the most demonstrated with time. And, trying to push for the preservative-free one. So just because some of the potential preservatives could be like neurolytic. So you want the preservative-free one. And I don't know if y'all have this happen in your shop, but we have like an order set built in, and half the time the nurse still bloody gives it IV. And at least in this scenario, this blooper is actually okay because they still get some extension of the block duration if it's given IV. So at least it's not the end of the world. A lot of times also just like do it perineural as well and just order a second vial. I don't know what y'all do, but for whatever reason, our nurses just can't figure that out. Um, Kind of so talking about clonidine, um, a lot of studies said, maybe get about a couple like 2 extra hours out of that in terms of duration extension. But the one thing is like similar to, IV, these alpha agents, they're still showing even administering perineural, they'll still have like increasing orthostatics and fainting and sedation. And I kind of think about our grandma that we're sending home with some rib fractures, and you're blocking her, and then you're going to send her home and she's going to like pass out from her block. And that seems like, is that really the best option or not? Another alpha agent, dexmedetomidine, pretty similar side effects, but a little bit better in terms of duration in some of these studies. And then I don't know how many of you are using, epinephrine as part of your block armamentarium, but it does demonstrate that there is like a little bit of a boost in the duration, primarily because, all I saw was 1 hour, honestly. But, the thought is that you have that vasoconstriction to kind of keep all the anesthetic right there. But, it does seem like there is some potential neurotoxic component with not a huge extension of that block. So should we really be doing epinephrine? Does anyone have any strong thoughts about that? Not
I mean, I
really.
rarely use it. Just I'm too lazy to use it. Yeah, I rarely. I don't know if anybody else uses it at all, but I never ever use. I just don't use it. And I know some people like to use it because they define if it's intravascular or not, or because the patient gets tachycardic response. I just, if I'm going to use anything, I try to make it simple and use a single agent.
Yeah. And
It's interesting that
yeah,
Nysora, I think, actually, they were big fans of Epi, right?
yeah,
Yeah,
and
it's all. I mean, there's a lot of stuff Nysora says that I blatantly disagree with, but I think that I mean, if you're an anesthesiologist and you have a mixing table and you have plenty of time, I think fine, you can try whatever you want. But I just don't think it's an additive that makes a lot of sense to me.
I also think too that whole intravascular thing is a little bit more kind of in the landmark based block time too. So I feel like that's kind of also a faded benefit in our current realm too. So kind of coming out to buprenorphine, it's that lipophilic partial agonist. It kind of seems to work better than all the other like opiate agents. A little bit of a varying dose in terms of what you use. There's kind of like 0.5 to 0.1 mics per kilo. But the duration on this is pretty impressive. A lot of, in RCTs, kind of looking at like an 8 hour duration extension, which is kind of impressive. And kind of along that line of Dex. In the anesthesia literature, it does show that you have like an increase in post-op nausea and vomiting, and people get some pruritus from it. But on the scale of it all, if that gives them another 8 hours of pain reduction, I think that was kind of a decent risk-benefit ratio there. So this was kind of a big, just kind of a reference point that I thought was like a really nice chart looking at, kind of like a more recent review from 2023, looking at all the different like adjuncts and kind of, looking at all the different RCTs and kind of compiling what those different numbers are. And I took this and added some other things and kind of simplified it to this. And so this kind of looks at, what dose are you going to use? How much does it cost? what is that, what is the duration that you're adding? What are the big side effects? So, I thought this was kind of interesting to kind of look and compare here. But, when I kind of look at this, I feel a lot of us are currently using the whole, BuPiv and Dex kind of mindset. And, for our shop, that literally costs like $4 because, BuPiv is like 3 and Dex is 80 cents. So, I mean, great price point to kind of, allow your pharmacist and everyone to approve that. But the kind of one thing I really wonder is, if we're really kind of going, to what we think may be the best duration and the minimizing your lasts and kind of minimizing car toxicity, that Ropiv and buprenorphine is really only $13 more and has minimal extra side effects. So I kind of, I'm really kind of wondering, is that kind of a reasonable direction to go to in terms of an ER realm? And then, alternatively, should we just jump on that rec train? There's a lot of other kind of agents that are like floating around, but there's not a lot of literature on those. So just kind of curious, does anyone have any thoughts about doing the whole like Ropiv and buprenorphine combo?
I've never tried it. I don't know if anybody else has tried it.
Has anyone even used like buprenorphine as like an adjunct? Because I have not. We actually don't even have the like we have buprenorphine in our hospital. We actually don't even have the little vial that you would use as a perineural agent adjunct.
I think Joe had an interesting point in the chat about if you give bup as part of the block and then the patient needs breakthrough opiates, how are they going to interact with each other?
I don't know how much, how much systemic absorption is really going to be there with that, that strong partial agonist. How is that going to affect the systemic piece? I don't know that. I didn't see any comments about that. And, it still seemed like, at least if I recall correctly, the studies were still giving opiates along with the buprenorphine. They're still kind of looking at, comparing the MMEs between the different blocks. But so I don't know if there's like enough, like, minimal enough side effects that it doesn't affect that too much. I don't know, but as a fair, interesting point. Do you have any other thoughts about rec? The one thing too is, I mean, I think it's whether or not you can get the rec or not. And then, yeah, also too, if you start having nurses go ahead and push some of these agents instead of giving you all of them, and then you have nurses like pushing clonidine and epi on these patients, that could get a lot more sloppy. So if you can't get it in that, like already prepared vial, I think the rec could be a little bit messy, but I don't know how to feel about rec because I don't really see much literature on it.
Seems like the benefit from your previous table really just does not support it. If Dex and Bupe just blow all the other things out of the water and have really minimal side effects, why would you do the other stuff?
I'm with you, the same thing.
I
We do
agree.
we do bupiv and dex for the same reason, because there's great evidence on it, and it's hard to ignore that evidence and get it through pharmacy and get all the protocols in place to be able to do these adjuncts. So until another study comes out that supports some of these other adjuncts, we don't do them at our shop.
So just one question, and the reason, again, no Dex with ropivacaine because of crystallization concept. Is that so? We kind of bumped into this, and we had pharmacy ask us about this. So then I did some digging. I know it's in the literature. I actually pulled up the articles of it in the literature. All of them are done under microscopes to show these crystals forming. And then so I emailed 3 anesthesiologists around the country, and one at the Brigham, Alex Stone, and we had this long conversation about this. And he felt that was completely nonsense, and says he uses it all the time. So I'm kind of a mixed. I don't know the answer. Every anesthesiologist I asked about this kind of laughed and said, "What do you mean? What are you talking about? Like, who cares?" But it is in their literature that adding ropivacaine and dexamethasone will cause some crystallization formation. Again, in vivo and not in vitro. And if anybody has better knowledge of this, I would love to hear it.
I don't have better knowledge, but one thing to consider is this a pre-formulated or are you mixing it at the bedside? Because if you mix it at the bedside, I can see how there's just no real concern at that. If there's like less than an hour between mixing and giving. However, if it's mixed in the pharmacy and sits in a fridge for like a week, that I could see could possibly raise some concerns.
Yeah, we're mixing at the bedside. We're just ropivacaine and then adding 6 or 8 or 10 or whatever dose of dex you want to use, and using it for blocks, especially for like whatever. So it'll be at the bedside, and that's what I've come down to and started doing. Even though I know that I may be the one that was a chicken little and said, "Well, it's going to cause crystallization." I apologize for that, but that was based on their literature. And then I would love for you guys to ask. Please do not take it from me, but be interesting to have all of us ask our anesthesiology colleagues and see what they say. Like, hey, I heard this. The guy Arun's crazy. You're like, yeah, he's crazy. And then just we all get this like it's no, everybody's doing it.
Yeah, so I talked to my anesthesia team for our like rich people hospital who does all their ortho cases there. And they said they like, oh, it does cross crystallization. And they Googled it like in between cases, like, yeah, you're right. I'm still gonna keep doing what I'm doing. And I was like, okay, great. Because they mix right at the bedside, nobody cares. And
Yeah,
so he does,
I
yeah,
asked
Bupe
three
and
big-
Dex.
I asked 3 well-known anesthesiologists that all lectured at Astra, and the only person I haven't asked is I'm gonna ask a couple people this time when I go, and just really kind of pressure test it, because it seems silly that it would be great that we just have ropivacaine and dex and we're done, right? That would be our long-acting agent, and it would be a standard and simplified, and we wouldn't have to dick around with bupivacaine. Sorry for the cursing.
Yeah, I think
Rune,
Rope
yeah,
and Dex.
I asked our pharmacists about the University of Colorado and Denver Health, and they were kind of surprised. I think they were more concerned about sort of what Dan was talking about, if it gets mixed far away, but as long as it's at the bedside and used pretty quickly, they were kind of in agreement.
Yeah, I think this is all in vivo versus in vitro, and I just don't know the answer. And so I am going to talk to a bunch of anesthesiologists at Astra and see what they say. And hopefully I get at least a little clarity and at least just what everyone else is doing. Because if everybody else is doing it, then it just seems like we should do it too. That life works, right?
It is kind of interesting. A lot of those like precipitation studies are all kind of like older. And then if you look kind of in the last 5-6 years, there's a lot more of studies actually just using ropiv index as if that prior thing never happened. So it's kind of bizarre.
There's a lot of studies that actually include Ropi and Dex already as outcomes. So that's why I think there's not enough like Aquapos in terms of like, or like there's enough that we don't think it's harmful, I think. And I guess publishing a big series with no bad outcomes would be important. I think regarding the hyperglycemia thing, when you look at the literature, we looked at this recently, the levels of hyperglycemia are minimal. It's like
10.
most blood glucose, yeah, it's less than that. It's like it went up by 3 or 4. And so I also caution, because I know at our shop, we have been also a little bit hesitant to roll out things that are different, but looking at the data, I think it does provide a significant benefit. And so these side effects are pretty minimal. The worry with buprenorphine from my standpoint would just be like, if they're very small doses, it's like micro kilograms that you're giving. So I just wonder like how easy that is to mix, and like, is there a big downside if you give a lot more than that, right? Could get the systemic problems and make downstream pain difficult to treat.
Yeah, great points. Cool. So I don't know, maybe we just go ahead then and go with the ropiv index. I mean, I think those that have like the cleanest safety profiles together, if they can safely be put together.
Yeah, I think from we've talked about this now a couple times, and I think if more and more of us, if you know, like sometimes lectures, the goal of the lectures to do one thing, if more and more of us are using Dex when we use anesthetics, it may be the ideal thing to do, right? Like we should just think of it more often, because I forget it as well. So I think it's just a really good reminder that we should be thinking of this as a tool to prolong our blocks.
Yeah, I mean, from the registry standpoint, the initial data, when you looked at just Denver, when they published their abstract last year, BuPiv actually provided more benefit in their patient population when it came to pain relief, at least just in their data. We'll see what everybody else shows. But just speaking of this slide here, it makes me ask this question. I mean, I use BuPiv index more so than we just don't carry RoPiv. I've always been curious about this cardiotoxicity risks in BuPiv. Has there ever been any large trial against each other to know which one's safer? We talk about it all the time, but I've never seen a trial on it before.
I've looked at this years ago, and if somebody else has more current knowledge, please correct me. But I looked at this when we got ropivacaine in our hospital, and it was a lot of animal studies, and it was theoretical studies on binding duration. And if somebody has any more data, please correct me. But there was nothing at that point that defined. The only reason we added ropivacaine was because I didn't want somebody to have a bupivacaine last event, and anesthesia would have been like, why didn't you just use ropivacaine? Because I know that what they'll say. So we've kind of shifted to ropivacaine because it's standard. Same with nerve block needles. You could argue with me that nerve block needles, the blunt tips have no different outcomes. But I think that aligning with our colleagues reduces that finger pointing that will eventually happen when somebody has a last event. So that's the only reason I did it, Andrew. And I think I think you could argue the other way perfectly well.
I think this is another plug, and I give a plug for the registry every time, but that these are the types of questions that we'll be able to answer the more the people that join this registry and the more blocks that are added, because the volume of RoPiv or versus BuPiv or RoPiv dexamethasone plus versus BuPiv dexamethasone, we'll be able to answer these complications hopefully, and hopefully have answers.
Yeah, no, I totally agree. So I think this is these are all really fascinating points, and I think that I think there's like a standardization technique that would be nice that we all did eventually when we had some more of this data that said that you can use either one, or we're all just going to stick with ropivacaine and bupivacaine, ropivacaine and dexamethasone. Excuse me. I just like the alignment between upstairs and downstairs. So there's some level of kind of continuous kind of care that happens rather than you can't use this drug, we can use this drug. I think it's just silly, in my opinion.
Something I'm
I agree
actually
with
kind of
you.
curious about too is how much dexamethasone is everyone using? Because there's a little bit of variance with that in the literature. And then also when you're looking at crystallization, like I don't know if all these studies are equivalent. Like I'm looking at a few where they're doing like 1-to-1 ratios. So I'm curious how volume affects that degree of crystallization, and if there's like a fine tune where maybe you only need a little bit.
We use
I
4
use 8
milligrams of
milligrams, man, for no
dexamethasone.
reason.
Sorry. We use ropivacaine and 4 milligrams of dexamethasone in all of our blocks. I mean, it seemed like a sweet spot between slamming them with 10 milligrams of dex in our diabetic patients. And it also comes in 4 milligram vials, so it's just easier.
Yeah.
But no real head-to-head data that I know of. That's pretty much what our anesthesia colleagues upstairs recommended.
Yeah, ours comes in a 1 ml, 10 milligram vial, and I never took the time to draw it 0.8 ml. So somewhere there.
0.23 mLs, please. Just tell the nurse they'll pull it for you.
What do you guys think about the whole basic benefit of ropivacaine? I haven't dug. Does anyone know more about whether that's hearsay or it's actually also true? And that's why I guess we kind of shy away with using epi with ropi.
David's question was, does anybody know about the vasoconstrictive effects of ropivacaine? I'm going to give you my opinion on this. All this is classic anesthesia data, which is all in vivo, and they inject it into a mouse and look at vasculature, and then they extrapolate it to humans. I think that's probably what the data is. It's probably hard data to get, but I think it's that's where this is coming from. This is all the studies I've ever looked on last cases are all based on even the fat emulsion is based on animal studies, right? It's they kill these animals and then they bring them back to life. So I think it's probably just animal studies.
That's what I saw when I tried to dig through it all. And I mean, honestly, that whole like CNS thing was nothing impressive. It was, looking at bupiv versus ropiv and, at pretty higher doses, and, the bupivacaine group, they had some mild increase in like CNS symptoms. It wasn't like they like seized or died or anything that. It was like, I feel more anxious. It was kind of like what I saw in terms of that like CNS piece of that. Cool.
Great discussion, guys. This is awesome.
Ready.
Just in case anyone has to leave at the half-hour mark, I put in the next session information. Bob, if you have more slides or more discussion points, I'm ready to go. Bring it.
No, I'm good. The only thing I've left is a picture of a turtle from my vacation, but that's it. So
Sweet. Do you think we run into a risk if we do like, I don't know, 4 milligram dex with bupivacaine or ropey, and anesthesia upstairs is using higher doses? Or just is there a risk if we aren't doing what the upstairs people are doing? Are we running a risk?
I thought about this question, and then Alex Stone, who actually presented this group probably 6 months ago, actually even looked into this question and just a preliminary analysis on the factually.
Andrew, your speaker's not work. Mic's not working again, man. Time for you to invest in a new laptop, I think, buddy.
I just fucking got it.
This is a daily occurrence in the lives of the Harvard doctors. Their fucking Zoom doesn't work.
I guess the main point is know what your upstairs people are doing, and if you're significantly different from it, you should have an explanation.
Yeah, tell them about the crystallization. They'll teach them something new.
They'll just laugh in your face. Okay, so our next session is in the chat on the 7th of March. Kat will be discussing some billing and coding block stuff. So looking forward to that, so we can have that as part of maybe an ROI discussion. And then I also put Andrew's email in there if you want to join the block registry, and I would encourage everyone to do that. I think that takes care. Oh, and is anyone going to Azra? Anybody else going to Azra?
We should all have a Blockheads drink session or whatever. You guys can, if everybody's going, please email me. We'll set something up.
Sweet.
Where's it at this year, Rune?
San Diego. San Diego. It's on. The dates are.
It's like March 28th, 29th, something like that. Because that's my anniversary. And that's why I'm not going.
21st to 24th. 21st to 23rd.
All right. Cool.
So if everybody's going, please email me, and we can all hang out. Be fun. They're actually running an ED session where they're going to have hands-on with. They found an ED doc. There's a anesthesiologist, can't remember where she's from, North Carolina or something, and she's working with the ED doc at her center. So they are setting up a little like how to do ED blocks.
Sweet.
Yeah.
All right. Well, thank you, everyone. If there's any further questions, feel free to stay on. Otherwise, meeting's over, and have a great rest of your day.
Thanks. That was great.
Thank you.
Awesome, Bob.